Let's jump straight into evaluating memory loss in older adults for Step 2 CK. This requires a really strict triage algorithm. Basically, we have to differentiate normal aging, mild cognitive impairment, dementia, and depression from acute, life-threatening delirium. If you miss a step here, you're going to miss completely reversible conditions.
So picture this. You have a 78-year-old patient coming in with quote-unquote memory problems. Now, it's super tempting to just jump straight to a dementia diagnosis or order an MRI right off the bat, right? But the actual next best step is a structured cognitive assessment. If you skip this, you skip mandatory triage.
Section 1, Memory Concern Triage.
Okay, before we even think about chronic memory loss, we have to assess for fluctuation, inattention, altered level of consciousness, or disorganized thinking. If any of those are present, your diagnosis is delirium until proven otherwise. Stop what you're doing, confirm it, and treat the underlying medical trigger. It's only after you've ruled out delirium that you can proceed to screen for depression, check baseline cognition, and look at their functional status.
Let's break down that step-by-step logic. If the clinical course is acute or fluctuating with inattention, boom, think delirium. Now, if a depression screen comes back positive, maybe they're presenting with low energy, sleep changes, and anhedonia, think pseudodementia. What if a cognitive screen is abnormal, but their functional status is totally intact? That's mild cognitive impairment. And finally, if that cognitive decline actually interferes with their daily function, then we're looking at dementia.
Section 2, Suspected Impairment Workup. For initial cognitive testing, we use tools like the 6-item screener. It gives 3 points for memory, like recalling 3 words after 5 minutes, and 3 points for orientation, specifically the current year, month, and day. If they score is 0 to 4, that mandates a comprehensive cognitive evaluation. That comprehensive evaluation escalates to more detailed tests, like the MMSE, MoCA, or MiniCog. But here's the kicker. A primary dementia diagnosis absolutely requires ruling out secondary reversible causes. So every single patient needs routine labs and structural neuroimaging, typically a non-contrast CT or MRI, to evaluate for strokes, tumors, or normal pressure hydrocephalus. For that routine reversible workup, you absolutely must include a CBC, vitamin B12, TSH, and a CMP. For Step 2 CK, they love to test vitamin B12 deficiency and hypothyroidism as classic, totally reversible causes of cognitive decline. So if you see macrocytic anemia or cold intolerance paired with memory loss, that points directly to a metabolic issue, not primary dementia.
Section 3, Aging versus MCI versus Dementia. When it comes to differentiating these, activities of daily living, or ADLs, are your strict clinical dividing line. In normal aging, ADLs are completely normal. In mild cognitive impairment, cognitive domains decline, sure, but their functioning in ADLs remains normal because they compensate. Dementia, on the other hand, requires marked functional impairment. You've got to remember to distinguish basic ADLs, like bathing, dressing, and feeding, from higher-order instrumental ADLs, or IADLs. Those are things like managing finances, medications, and transportation. IADL decline almost always appears first, and that should immediately trigger safety planning.
Now, how do we distinguish depression-related pseudodementia from true dementia? It all comes down to awareness. Pseudodementia has a much more abrupt onset. These patients are actually distressed by their deficits, they have sleep or appetite changes, and they'll frequently just answer, "I don't know," to your questions. True dementia has an insidious onset. The patients are relatively unaware of their deficits, and instead of saying, "I don't know," they'll often confabulate answers. Collateral history is absolutely essential here because patients will under-recognize their own deficits. In normal aging, the patient is usually the one reporting detailed incidents of forgetfulness. But in dementia, it's the family reporting recent memory declines and ADL dependence. And when you hear that, you need immediate safety screening. Ask about driving safety, getting lost, wandering, and medication mismanagement. Never, ever simply reassure a patient with progressive dementia who continues to drive unsafely. You have to recommend a formal evaluation. You also need to screen for caregiver burden, look out for exhaustion or financial strain. And hey, don't forget to respectfully address sexuality in older adults. Review their medications and look for reversible causes for dysfunction, but never just assume sexual inactivity.
Section 4, Delirium and Reversible Causes.
Polypharmacy and anticholinergic burden are massive triggers for delirium in older adults. High-yield offenders here include over-the-counter antihistamines like diphenhydramine, bladder antispasmodics like oxybutynin, opioids, sedatives, and TCAs. If you get an older patient presenting with acute confusion right after starting a new med for seasonal allergies or urinary incontinence, your next best step is a meticulous medication review to find and stop the offending agent.
Here's a huge exam trap: hypoactive delirium. While we often associate delirium with hyperactive agitation, hypoactive delirium is actually way more common in the elderly. It presents with lethargy, somnolence, and a flat affect. Because of this, it is frequently misdiagnosed as severe depression or even a new stroke. Always check for inattention and fluctuating consciousness.
When managing delirium, your first-line approach is always non-pharmacologic. Delirium leads to falls, aspiration pneumonia, and it permanently increases the risk of long-term cognitive decline. You prevent this through environmental structuring. We're talking noise reduction, bright daytime lighting, and early mobilization without physical restraints. Because delirium complications so often alter a patient's functional baseline, you have to do safe discharge planning. Evaluate if they can return home with home health for nursing and therapy, or if they need a skilled nursing facility for short-term rehab, or maybe long-term care when their ADL needs completely exceed what can be done safely at home.
Managing the neuropsychiatric symptoms of established dementia pretty much mirrors delirium. You start with non-pharmacologic interventions, a stable environment, a structured routine, and gentle redirection. You only escalate to pharmacologic interventions, like off-label low-dose antipsychotics, when there is a severe, immediate risk of harm.
And finally, an absolutely crucial exam trap: avoid benzodiazepines in the elderly. Whether it's for insomnia, anxiety, or behavioral symptoms of dementia, benzos are strictly contraindicated. They frequently cause paradoxical agitation, which makes the confusion dramatically worse. They also severely exacerbate cognitive impairment and cause profound ataxia, which leads to devastating falls and hip fractures. If a benzodiazepine is listed as an option for agitation in an older adult, it is absolutely the incorrect choice.